Okay, I have 6:30. Time to get started. Good evening, everybody, and welcome. My name is Daniel Southern. I am the Director of Interventional Orthopedics CT. We are the only Regenerative affiliate in the state of Connecticut, and one of the few Regenerative affiliates in the Northeast that treats spine. And that is because I did a fellowship in spine and sports medicine at the Hospital for Special Surgery. Upon graduation, I spent the better part of a decade and more treating spines in a traditional orthopedic manner until I became disenchanted with that approach and began casting about for alternatives, and have been treating spines with regenerative orthopedics using Ortho Biologic injections for the past 8 years or so. But enough about me. I will throw up my resume at the end of the presentation for anybody interested in the finer points of my background. Our topic tonight is back pain, and I always like to start off the discussion of back pain with the few of the considerable myths associated with back pain. The first main myth is the myth of the injured back. Backs are not prone to injury. As humans, we are built to labor. Our backs are wonderfully constructed to help us do that. The majority of the back pain epidemic that we are suffering is due to bad habits of modern life. And I refer specifically to carbohydrate-rich diets and sedentary lifestyles. Now, the majority of acute back sprains, when they do recur, there is full recovery. Only a minority of patients develop what we call a fear-avoidant behaviors leading to deconditioning and, ironically, an increased risk of re-injury of their back. This is the frightful person who's afraid to do anything for fear of hurting their back once again. And as a result, they become more and more deconditioned and out of shape. And of course, then they're even more vulnerable to repeat injury. There's the myth of doing too much. You've heard this before in your family, I'm sure. The bottom line is that your back, it hates sedentary lifestyles, just hates them. Backs respond to regular use, activity, and exercise, and that is a theme that is quite clear in the medical literature. There is the myth of obesity causing back pain. This is a myth that's very old and is dying slowly. For decades, all medical practitioners would tell people with back pain, oh, you're a few pounds overweight, lose some weight and you'll be fine. Well, we've done the studies. We've taken people with back pain, we've made them lose not just a little weight, but a lot of weight. And what do you think happens to their back pain? Not much. The goal of treatment should be fitness, not weight loss. If you get into better shape, you're going to lose a pound or two, but you'll feel better because you're more fit. The myth of the neighbor's advice. This one, I hear this weekly in my clinic. The patient walks in the door and says, my neighbor says that he has the exact same pain as I do, and they say that I should. So the point is, everyone is an expert on back pain. And why do you think that is? Well, that's because everybody's going to have back pain or has had back pain. The global lifetime prevalence, this is global, 60 to 80% of all humans on the planet will have significant back pain in their life. Just a couple of things to keep in mind. Your neighbor does not know your diagnosis. You do not know your neighbor's diagnosis. And chances are very good that your neighbor is not a doctor. The myth of the MRI. MRIs rarely reveal the diagnosis. The exception is a clinically significant protrusion. However, you already knew that. And by that, I mean, if a patient walks in the door and says, Doc, I have terrible pain in my back and butt, and it radiates down my leg and my little toe is numb, I can tell them you've got a disc protrusion at L5 S1 and it's hitting the S1 nerve root. So then I order the MRI to confirm my clinical impression. And that's generally how MRIs should be ordered. You need to avoid fishing expeditions with MRIs. It's not productive. The associated myth of the MRI is the myth of the disc protrusion. Studies show that disc protrusions are found everywhere in the spine and from an early age, and they mean nothing at all. A disc protrusion is only significant if it's found on the side and at the level that matches a patient's symptoms. Then we come to the myth of the pain generator. And this is a myth that is pervasive in medical schools. This is how doctors are trained. And this is the idea that back pain is caused by a single focus. The idea that if you can find that one thing that's causing the pain, the back pain will be solved. This is simplistic. It's not realistic, because anybody who spent any time treating spines in medicine knows that low back pain is never, or very rarely, one thing. Back pain is complex because the spine itself is a complex structure. Back pain has contributions from a number of interconnected spinal tissues, and that's important to remember. So let's talk about the standard treatment algorithm as it stands today in orthopedics with back pain. You start with low back pain. The majority of you will rest a day or two or three and take some Advil, and you're gonna be fine. But if you're not, and you call the primary care physician, he'll suggest physical therapy, which is a wise thing to do. And most of the rest of you who haven't responded will respond with a little bit of therapeutic exercise and stretching. But if you don't respond to that, you call the primary care doc up and he orders an x-ray. And an x-ray at this point is fairly worthless. It doesn't show much of anything. If you had fallen off a fence and developed back pain, an x-ray could be very helpful in case you have fractured something in your spine. But then that x-ray should have been ordered way back here at the beginning of the onset of back pain. So the x-ray doesn't show much. The next step is to get an MRI. Now, the MRI, if it's a fishing expedition, people are straining to see something, they're guessing, they're thinking maybe, and generally what's advised is an epidural steroid injection. And the first one can be quite miraculous and can help with back pain, and certainly can help with leg pain should you have that. But it doesn't last typically, and when it wears off, you go back to the doc and he suggests another one, and then when that wears off, you come back and have another one, and you see the type is getting smaller and smaller, and that's because epidural injections have diminishing returns over time. So what happens next? Well, at this point, the pain doctor generally has in charge of you, and they'll probably suggest some diagnostic facet blocks or a sacroiliac joint diagnostic injection. And if that helps a little bit, the next recommendation is going to be a burn the nerve procedure known as a radiofrequency denervation. And that's never terribly helpful. And when it's not, you're then probably sent to the orthopedic, at which point your chances of getting spine surgery go way up. Now, if you have seen a spine specialist at the point of getting an MRI, and that's quite possible, and especially if you have leg pain as well, then your chances of going straight to surgery are really quite increased. So surgery can be helpful, particularly for leg pain, but not so much for back pain. So when you show up after your surgery still complaining of back pain, what happens is you tend to have another surgery. This one's called fusion. And the secret of spinal fusion is that it leads to more fusion. And when that doesn't work, you're left with the whole calamity of the pain patient. Narcotics, back braces, pain pumps, and spinal stimulators. So what's wrong with this algorithm? What's wrong with low back pain treatment? Well, the medications. Non-steroidal anti-inflammatories, Advil, they're okay in the short run and can be quite helpful the first few days of a back sprain, but in the long run, on a regular basis, they're dangerous medications, particularly as we age. The side effects include GI bleeding and renal failure. Steroids. Epidural steroid injections have never been shown to change surgery rates. Epidural steroid injections show decreasing effectiveness over time, and steroids themselves are absolutely terrible. They are toxic to the body. They weaken ligaments. They kill cells that keep joints healthy. They increase your blood sugar. They lower your immunity, and they decrease your bone density, among other things. Finally, we come to narcotics, and we should all, at this point, understand the dangers of narcotics in terms of addiction and complete dependency on them. What's wrong with low back pain treatment? Radiofrequency denervation, otherwise known as the burning the nerve procedure. This is technically known as a medial branch nerve radiofrequency denervation. And the whole point of denervating the medial branch nerve is to take sensation away from painful arthritic joints in the spine, as seen down here. This is the spinal nerve, and as the nerve branches, this is the medial nerve. It's a branch off of the spinal nerve. And then it sends two little twigs, one to the facet joint above and one to the facet joint below that level. The whole idea of the medial branch nerve radiofrequency denervation is to burn the nerve out, and you burn it out right at this point here. You lay a needle down here, you plug in a radiofrequency generator, it heats up the needle tip and it burns the nerve out. That destroys sensation, this twig and this twig, coming from the two facet joints. Unfortunately, it also destroys this twig. Where is this twig going to? This twig is supplying a muscle that sits back here called the multifidus. And this is a very important muscle. All muscles are important. Any muscle that loses its nerve supply will atrophy and disappear. And if you lose this muscle is a very important spinal stabilizer. And what can happen is it can result in spinal destabilization. So this is not a great idea in terms of treatment for back pain. What's wrong with low back pain treatment? Surgery discectomy, otherwise known as laminectomy discectomy, also known as microdiscectomy. This is the removal of the lamina, which is a bone that prevents entry into the spinal canal. Once you're in the canal, you remove the hunk of disc that's protruding. And this can be a successful operation, particularly if it's aimed at solving leg pain, which it usually does, at least for some time. Unfortunately, it does nothing to treat a degenerated disc or back pain in general. And with laminectomy discectomies, there is a possibility of a post-laminectomy syndrome estimated to be prevalent in anywhere from 5 to 15 to 20% of patients who have undergone surgery. And this is where, within a few months after surgery, your leg pain returns. And the reason it returns is that it's presumed to be scar tissue from the procedure itself that envelops the nerve, squeezes it, and causes irritation. And then you have chronic radiating leg pain. That brings us to spinal fusion. Spinal fusion destroys the motion segment. The motion segment is the smallest unit in your spine. It consists of two vertebrae and the disc that connects them. Here we have pictures of spinal fusion. These are screws going into 4 levels of vertebral bodies. We have destroyed 1, 2, 3 motion segments. In other words, these motion segments are no longer moving independently. They are now one big block of bone, and I will highlight that to show you. This is a big, big block of bone now. And what this big block of bone does is it acts as a tremendous fulcrum, which then creates breakdown at the transitional level, above and below the fusion level. And what this results in is you got to have more fusion. You come back to the doc and they say, well, we got to extend the fusion up to here and down to here. And that's what happens. Lumbar spine fusion fails to solve low back pain in an estimated minimum of 20%. And I took this right off the spineuniverse.com website. In my experience, I would say an estimated minimum of closer to 50%. And the truth is, it's probably higher than that. This is a terrible, terrible procedure when it's done for back pain. Don't get me wrong, sometimes it has to be done. If you have suffered trauma, you've been thrown from a car at 80 miles an hour and your spine is crushed and destroyed, yes, we have to fuse you. But when you apply it in the community for back pain that hasn't responded to the standard treatments, it's usually bad surgery. So what's the interventional regenerative orthopedic approach to low back pain? Number 1, We preserve the native spine structure and tissues, and this is very, very important. The design of the human spine has been refined over a millennium. The minute you go in and start changing it and futzing around with it, it comes at a cost, which is usually more pain. We treat the whole spine. We don't focus on just a single part of the spine. We treat the whole spine because that's the only way we're going to get a positive response. We use the body's ability to heal itself, and we'll come to more of that in a minute. And we're using only needles. This is not surgery. So what we're doing is we're preserving the native spine structure and tissues. That means that we do not do repeated steroid injections that destroy cartilage and ligaments. We don't do burning of the nerves and wasting muscles with radiofrequency ablations. We don't cut out discs or bone with scalpels. We don't fuse one bone to another with screws and plates. We don't insert spacers or other hardware between vertebrae. And we don't put in pain pumps inside the spinal canal. We treat the whole spine, not just its various parts, not just the joints versus the discs versus the ligaments versus the muscles versus the nerves. This is the piecemeal approach that is supported by insurance today. I cannot, if I am treating you through your insurance, inject your facet joints and do an epidural at the same time. They won't pay me for both. I have to do one, and then I have to do another at a completely separate time. The human spine is a complex structure of interconnected parts. It only makes sense that you have to treat it in multiple fashions and address multiple parts to get a positive result. This brings us to the motion segment. This is the most basic unit of the spine. It consists of two vertebral bodies and the disc in between them. The motion segments are connected via ligaments, which are not shown here, muscles, which are not shown here, joints, which are shown right here, and nerves, which are running up and down the spinal canal and exiting through the foramina right here. If you have dysfunction in one segment, it affects the segments both above and below, and you have to be aware of that. To treat a dysfunctional spine segment, you have to treat all of the elements that hold the segment together. That's very important. That's a concept that takes a while to learn when you're in practice treating spines. Which brings us to number 2, use of the body's ability to heal itself. How do we do this? This is Ortho Biologics. Ortho Biologics is a term that comes from orthopedic injuries to the spine that are treated with a patient's biologic repair tissues. We call that Ortho Biologic Treatment, and we're injecting Ortho Biologics. What are they? The repair cells of the human body are platelets. These are small cells found in the blood. Their first job is to arrive at an area of injury and form a blood clot so you don't bleed to death. Right on the heels of that, they begin secreting powerful repair hormones, which are contained in millions of small little bodies inside this tiny little cell called alpha granules. They begin to release this stuff, and these are repair hormones that begin to direct repair to the damaged area. We also use adult mesenchymal signaling cells, otherwise known as MSCs, otherwise known as stem cells. And these are multipotent cells that we have found in every niche of the human body. And this is some new information. We did not know that the human body had adult stem cells until about 10, 15 years ago. We thought they were only found in fetuses. Of course, these cells are slightly different than the cells that are found in fetuses, but we're not here to talk embryology. The stem cells we use in Regenetics they come from the bone marrow. We use bone marrow MSCs. And these MSCs have a particular ability to become the tissues of interest. That includes cartilage, tendons, ligaments, and bone. So our clinic, like all Regenetics clinics that treat spines, we inject all of the spine, and we're using Ortho Biologics in various fashions. We're using a platelet preparation known as platelet lysate to treat nerves. We're using platelet-rich plasma into discs, joints, and ligaments, and we're using stem cells inside the discs and sometimes inside the joints. I want to pause for a moment at this juncture for people who can't stay throughout the entire lecture tonight, and just throw out a contact number in case you need it. Moving on. So orthobiologics, again, we're using platelet-rich plasma for joint cartilage. We're using platelet lysate for nerves. We use platelet-poor plasma for muscles. We use PRP, which is platelet-rich plasma, and or platelet lysate for small ligament tears. We use bone marrow aspirate concentrate for larger ligament tears and to treat discs and severe cartilage loss. So in other words, if you have greater pathology, that's when we usually step up to the stem cell treatment. How do we do this? This is done through precise injections of these repair cells, known as orthobiologics, into damaged or malfunctioning tissues in the spine. When we do this, it triggers an acute inflammatory event that mimics an acute injury. The body heals itself through inflammation, and what we get is a repair response right at the area of injury. That's the near response, and then a far repair response. The orthobiologics we have injected summon other repair cells to the area. We then protect the area through bracing and activity modification, and then we allow the body to effect repair. And as I said, repair is achieved through inflammation. So anything that interferes with inflammation, including NSAIDs, statins, steroids, ice, we don't use those. We avoid those. We go through 3 phases of treatment. Inflammation is the first phase, proliferation of repair tissues is the second, and the final phase is remodeling. And all of this occurs over a 1 day to 12 to 16 month period. What causes back pain? Well, this is the billion-dollar question. But as I stated earlier, the one thing we can be sure of is never just one thing. If back pain were one thing, it wouldn't be a billion-dollar industry. Backs are complicated. Multiple contributors to any one back pain syndrome are the norm. Potentially painful structures in the back are many. And these are things that have a nerve supply. They include muscles, ligaments, joints, discs, bones, nerves themselves. So we're going to discuss each one of these quickly in turn. Muscles. Muscles do one thing. They don't have a brain. All they can do is contract. When muscles sense a problem, they contract, and they contract to stabilize or splint a painful area. In so doing, they can quickly become a source of pain in and of themselves. When they become overwhelmed and chronically contracted, they form what's called a trigger point. And this is just a contracted band of muscle fibers that's so tight, blood can't get into the area, and the fibers at the center of the contraction begin to die and become necrotic. We use trigger point injections to treat this type of condition. We put a needle right inside a trigger point, and we basically mechanically needle the area. It doesn't really matter what we inject. And what this does is it helps blood recirculate in the muscle, and it restores normal muscle architecture. So that can be very helpful. But muscles are usually a downstream problem, meaning they're trying to solve a problem that they can't solve. So the pain is usually coming from elsewhere. Muscles are reactive. Spinal stabilizer muscles. These are known as the multifidi. Funny word. This is a schematic of multifidi muscles. They're very small muscles. They go from one short segment to another, but in aggregate, they go from the base of your head to your tailbone. And in aggregate, they stabilize. They're very, very important stabilizers of the lumbar spine. These are the muscles that are sacrificed when you do the burn the nerve procedure. When they become weak or they atrophy and they disappear, such as after burning the nerve procedure, that's when back pain can set in. Studies have shown that atrophy, which is the wasting of these muscles, wasting of the multifidi, atrophy is directly correlated to back pain. Here's a picture of muscle atrophy. This is normal. You see all this back here? This is fillet. This is all muscle. The multifidi are the muscles that are closest to the bone right here. This is mild atrophy. You see that there's some white signal intruding. That white is fat. And this is what happens when a muscle begins to atrophy. Fat moves in. This is moderate atrophy. There's more white. And this is severe atrophy. Almost nothing but white, very little muscle down here. How do you treat this? Well, we send you to physical therapy. We teach you strengthening exercises for your back, because a stronger muscle is a less painful muscle simply because it can contract longer and it's not as easily overwhelmed. And then we've learned in Regenerative that if we inject these muscles with platelet-rich plasma, we can stop the inflammation that's occurring with the infiltration of fat. A recent study here by James in 2021 showed that when fat invades a muscle, it brings with it chronic inflammation. So if you inject a platelet-rich plasma, you can address that inflammation, and you can also stimulate growth in the muscle, which in concert with therapeutic exercise can be very helpful to restoring normal muscle architecture. That brings us to ligaments. Ligaments can be painful, and your spine is absolutely held together by ligaments. And this is a wonderful drawing showing you all the ligaments that you never see in just the basic schema of the bones. But there's ligaments everywhere holding the bones of your spine together. Now, as we age, the vertebrae comes closer together, and what were once very taut ligaments become kind of lax and loose. And what this does is it leads to instability. And instability alone can cause back pain. Ligaments are also injured in violent sort of whiplash type injury. In fact, whiplash from a motor vehicle accident is thought to be a microscopic injury to the fibers of ligaments. And this is why many people after car accidents have chronic neck pain. How do we treat ligaments? We treat them with a technique called prolotherapy, which has been around 85, 90 years now. Prolotherapy is defined as a growth factor or growth stimulating injection. And this is a picture of it. It's usually done under ultrasound using a probe. The needle is inserted, and this is what you see. This is the needle under ultrasound injecting the ITB band over the side of the knee. And this is the knee bone here. What prolotherapy does is it addresses laxity in connective tissue insufficiency, CTI. Prolotherapy strengthens ligaments and enlarges the interdigitation of tendon and ligament fibers with bone, otherwise known as the tendon-osseous junction. Here's a picture of rabbit tendons. These are normal rabbit tendons. The big thick ones here are treated rabbit tendons. These were prolotherapy with a standard 12.5% dextrose pro-inflammatory proliferative solution. We've known for a long time that if you do this, you can make a ligament thicker and stronger. What we've learned in Regenerative is that if we use a patient's repair cells, such as platelets, instead of 12.5% dextrose, it works even better to strengthen ligaments and heal tears in them. Joints can be painful. Your spine is held together by joints, and spinal joints can become painful just like any other joint in your body. And that's usually through a process known as arthritis. The joints of your spine are called facet joints. Here's a picture of an arthritic facet joint. This is a normal facet joint. What's happening in an arthritic facet joint is, ironically, the cartilage is being destroyed by the cells that are alive in cartilage, known as chondrocytes. All joints undergo breakdown of cartilage and repair, and usually in healthy joints, this is in balance. In an arthritic joint, this is out of balance, and what's happening is cartilage is being broken down more than it's being repaired. And this is because chondrocytes are secreting enzymes that actually digest cartilage. What we discovered within the last 5 to 7 years is that all human blood products have chemicals that inhibit this enzyme activity. So it stops this digestion of cartilage. So when you inject PRP into a joint, what you're doing is you're changing a destructive chemical environment and turning it into a healthy, pro-growth chemical environment, which is a smart thing to do. The other treatment for joints is to reduce spinal instability, to increase spinal stability. How do we do that? Well, we send you to physical therapy and strengthen the dynamic stabilizers of your spine, which are your muscles. We do prolotherapy to your ligaments, which are the static stabilizers of your spine. And then we inject the multifidi, the muscles, and this also strengthens the muscles. So what we're doing is we're creating less instability at the level of the facet joint, and that's a good thing for an arthritic, painful joint. That brings us to discs. Discs can be painful. Discs are just large hunks of specialized cartilage They act as shock absorbers. They distribute axial loads in the human spine. They also act as spacers. They keep the vertebral body separated at a prescribed distance. And this is why you shrink with age, because as we age, the discs, which are mostly water, begin to lose water and they become thinner and thinner. And this happens at each of 36 levels in the spine. You lose a millimeter or two. At the end of your life, you end up at least a couple inches shorter than you were at your zenith. Discs can be painful. The disc is composed of an annulus, which is the ring around, and a center, which is a kind of like a jelly donut. The disc has sensation from the posterior third back. So all this area in here has sensation. You could take a hot poker and stick it into the front of the disc and you wouldn't feel a thing because there's no nerve innervation here. But this is called an annular tear. This is the annulus and it's torn and some of the center of the disc is pushing in here. And this is almost a disc protrusion, but it's not. We call it an annular tear. And it can be quite painful. And this is what it looks like on MRI. You get this bright white signal in a disc, and that's an annular tear. And it can be quite painful. And it's treatable. We do intradiscal injections, and here's a picture of what that looks like. It's a needle going into the L45 disc, and the dark stuff you see is contrast dye we're injecting. We've discovered that high-dose platelet-rich plasma injected into a disc with an annular tear can be very helpful in reducing pain and increasing function. This was first done by my mentor at HSS, Dr. Greg Lutz. He did a 2-year follow-up study showing that it was significantly helpful for the patients that were treated with platelet-rich plasma. In Regenerative world, however, we tend to use bone marrow aspirate concentrated discs. Why? Because it works better. So these are stem cells. Nerves, of course, can be painful. This is a schema of a disc protrusion. Here at the top, this shows the annulus has been torn and some of the center of the disc is pushing out, and this is a disc protrusion pushing on a spinal nerve. This is the classic picture of horrible radiating sciatic leg pain. This down here is also a painful nerve, but you see there's no disc protrusion pushing on it. But you see here we have an annular tear. And what's happening is some of the chemicals from the center of the disc is leaking out. This is causing what we call a chemical radiculitis or a chemical sciatica. But this nerve is just as painful as this nerve, which is being hit with a disc protrusion. Nerves become swollen when they're irritated. This leads to more compression. And this produces that horrible toothache-like leg pain, numbness and tingling and weakness down your leg. An irritated nerve also is sending inappropriate signals to the muscles that it innervates, causing spasming and cramping in your back and leg. How do we treat this? Well, we treat this in Regenerative world with platelet lysate epidural. Platelet lysate is a particular preparation of a patient's platelets. It comes from the word lyse, which means to cut open. We take their platelets and we put them through a fast freeze and thaw cycle. And what that does is it destroys the cell membrane so that we have access to all the contents of the platelets. And the contents of platelet creates a soup of growth factors and repair hormones, some of which are neurotrophic, meaning they're specific to nerves and to nerve growth. So this is a smart thing to do over a painful nerve. Now, the technique of epidural injection is exactly the same as the technique of epidural steroid injection. The only difference is that we're using a different injectate. This is the epidural space here. I'm outlining it. It's around what we call the thecal sac. There are various approaches to the epidural space, one of the main ones of which is, let's see, where did my pointer go? You can come in straight from the midline into the epidural space this way. This is called an interlaminar epidural, or you can come in from out here in what we call the transforaminal approach. And assume this is a needle. And what we're injecting is platelet lysate, and it flows into the epidural space, bathing the nerve, which is injured. And we can affect repair of an injured and damaged nerve in this fashion. So how well does this work? Well, here's a study that we did in Regenerative on platelet lysate epidurals. You can see at the top, we took 147 patients and injected them with platelet lysate epidurals, and 85 patients with the steroid epidural. And down here, we followed them for 6 months, and this shows the response here in the beige of the epidural steroid recipients, and in blue of the platelet lysate epidurals. And this is a functional report index score, recording reduction in pain and increase in functioning. And as you see, platelet lysate worked better and lasted longer. This is 3 months, this is 6 months. So let's, before we wrap it up, let's just look at a couple of diagnoses and compare the standard treatment to the regenerative orthopedic treatment. This is a person with chronic episodic back pain, and the last episode of his back pain was newly associated with radiating horrible right leg pain. We got an MRI, and this is what we saw. A large L5S1 disc protrusion. This is the most eye-catching picture in the MRI when you're first looking at it. This is what the protrusion looked like in cross-section at that level. But there's a lot more on this MRI. For example, there's this. This is a very degenerated disc. It is dark. It is collapsed. Compared to this disc, which is quite healthy. You see it's got a lot of white in it. White is water. Everywhere you see white on this MRI is water. And it's lost disc height. And you see the whiteness right in here. That's edema and swelling inside a bone, the 5th lumbar vertebral body. And that's because the bone is becoming painful because the disc is collapsing and not doing its job. So the bone has to take more weight than it's used to. So this is a problem, and this has to be treated as well. We have other problems here. This is a facet joint. You see this white line in the joint. That indicates a fusion, swelling, and pain. We also have water in this joint over here, and we also have, you see the squiggly line, that's an arthropathic, hypertrophied, more arthritic joint. That has to be addressed. This is probably one of the sources of this gentleman's chronic back pain. Finally, if you look here and here, you see the whiteness where there should be muscle. These are the multifidi, which are atrophied. So this has to be addressed as well. So the standard treatment here, in this case, is a right L5 epidural steroid injection. Maybe. If you go to a surgeon with this MRI, they're probably going to persuade you to go ahead and have the laminectomy discectomy, which, like I said, can solve the leg pain, but it's not going to do much for this gentleman's back pain. So how are we going to treat this gentleman? Well, the orthobiologic treatment is a right L5 transforaminal platelet lysate epidural to address his leg pain. But that will be done with bilateral joint injections to address his arthritic spine pain, along with L5S1 ligament prolotherapy to give some more support to this level here that's collapsing, and super concentrated platelets, which is platelet-rich plasma, injected into the atrophied multifidi, along with, finally, a return to physical therapy. All of this hopefully will solve not just the horrible leg pain, rather, it'll solve this gentleman's, or at least help to alleviate this gentleman's chronic episodic back pain. One more. This is a gentleman with stenosis. He also has chronic back pain, with leg pain that is specific with standing and with walking. When he sits, which is the hallmark of stenosis, he has no leg pain whatsoever. So this is his spine. And the first thing you notice about this spine is that it looks kind of like a toddler took a bunch of blocks and stacked them one on top of the other. This bone is a little pushed forward on this bone. This bone up here is a little behind this bone. It looks a little rocky. If you look closely, you see the central canal looks nice and roomy coming down until about here when it gets pretty tight, and even tighter right here. And this is the cross-sectional view of that level. And you can see the central canal is pretty darn tight. So this is called stenosis centrally, and it's at L45 is the level. Another issue we have is this. This bone, as I pointed out, is slipped forward on this bone. There's a fancy word we use for that. It's called L45 Spondylolisthesis. And that means that this level, just by definition, is not stable. So we've got instability here. We've also got it up here. This whole rocky appearance is from instability. And again, that comes with aging. You see all the discs are quite thinned. And as the discs come closer together, as you recall, the ligaments can become lax, resulting in instability. Then what we've got is severe facet arthritis. These are very cupped-looking facet joints. We've got a lot of arthritic back pain that needs to be addressed. And finally, this dark area here is the ligamentum flavum that runs up the back of the spinal canal. And you see how thickened it is. It's beginning to contribute to narrowing in the central canal. And if we're going to address this gentleman's stenosis, we need to address that as well. So the standard orthopedic treatment is going to be epidural, followed by epidural, followed by epidural until they stop working. And when they stop working, perhaps a burn the nerve procedure, and ultimately a lumbar spine decompression. And this is a surgery that's often performed with spinal fusion. So what's the ortho biologic treatment going to be? Well, it's going to start with injecting the ligaments once, twice, and then again. This is prolotherapy. We have to do a lot of treatments to address this man's chronic instability. But you must address the instability, otherwise you're not going to address the pain or the stenosis. Platelet lysate epidurals in conjunction with bilateral facet injections to address the arthritic pain, and ligamentum flavum injections to address the stenosis. That's interesting. How are we going to do that? Well, here we are. Here is the ligamentum flavum, this thick black ligament, and you see how it's beginning to squeeze the central canal. Here's a schematic of the spine with cutaway vertebral bodies, showing the ligamentum flavum. I'm trying to pull up my pen. Ligamentum flavum runs right here. I'm just tracing it down. And this is the back of the spinal canal. And that ligament is connected with the interspinous ligament, which is this ligament right here. If we inject the interspinous ligament right up to the ligamentum flavum, what can happen is we can get this ligament to tighten up and actually pull this ligament back a bit so that this ligament is no longer nearly as thick as it once was, and we've reduced compression in the central canal. This is one treatment that we do for spinal stenosis. Well, we're getting to the end, and I just wanted to quickly go back to the algorithm that I elucidated when we started and show you how it's changed. It's about the same up until the point of the MRI, at which point we're at a crossroads where we can do orthobiologic injection treatment. Now, we can do that at any point along the algorithm here for many of these other treatments for back pain. And if we do that, what can happen is we send you back to physical therapy, and in best case scenario, we have resolved your back pain and preserved the native tissues of your spine. So we've taken you completely out of the algorithm, which sends you down the surgical pathway here, which all in all is a good thing. These are patient stories. They're all over the website at regenix.com. You can look them up and read them at your leisure. I've gone on long enough. I'm happy to take some questions if anybody should have them. Anybody can just raise their hand if they have a question, and I'd be happy to address any that you might have. Well, I know that was long. I appreciate all of you hanging in there. If there are no questions, I guess we should conclude. Please feel free to reach out and contact us if you have any issues. We can make this as easy as possible for you via Zooms, remotely. It looks like we have no question. You're welcome, Jolene. Thank you for coming. I was saying we can make this as easy as possible. We can do a Zoom, particularly if you have films, and get them to me. We can review them remotely, and I can at least give you an opinion. Of course, doing an examination is also very, very important. So it would be ideal if you could come into the office. But the whole point of the lecture, I hope that everybody realizes that there are alternatives to the standard orthopedic treatment of spines. And it's much less invasive, and it's much less damaging to the spine. Yes, we have a question from Maria. Maria, would you like to speak? Maria is asking about failed spinal surgery. We treat that routinely. It's a big ask because once you've walked down that pathway to spinal surgery and have failed, you've usually had pain for quite a few number of years. So it's a tall order, but yes, we treat that regularly and routinely. and we do well with it. You need to keep in mind that what we do is a valid medical procedure. It has success and failure rates. It has a whole spectrum of response. But I can say honestly, I have never, ever treated somebody and found that they got worse from treatment. That doesn't happen. All we're using is needles for the skin and a patient's own repair cells. So we're doing very little damage in the spine. We're not leaving any hardware behind. Maria also wanted to know my opinion on physical therapy, land versus aquatics. Aquatics are reserved only for people who can't tolerate land therapy, and that's should be a very rare individual, somebody who's quite obese perhaps, and just so deconditioned that they can't tolerate being on land. But we do aquatic therapy, absolutely. But we want to graduate you to land therapy, which is always going to be much more intense than aqua therapy, as soon as we possibly can as part of treatment. I'm sorry, Maria, I can't hear you. I keep trying to unmute you, and still I'm not hearing you. Any other questions? Walter, would you like to speak? Maybe it's me. I can't seem to unmute people. Walter is asking, what is the source of stem cells? We get stem cells from the patient's bone marrow, and that we get from the big hip bones. You can get bone marrow from any bone in the body. We get them from the hip bones because there's plenty of marrow there. It's relatively easier to do from that location. And within the bone marrow are found these MSCs, otherwise known as stem cells. So that's where we get them. We concentrate them in our laboratory before we re-inject them into the areas of damage. We have a couple of chat questions. Do insurance carriers support this? We have, complicated question, complicated answer. We have almost 10 million people who are getting insurance coverage for these procedures. Unfortunately, these are all employees of businesses that self-insure the health of their employees. And what Regenerative does is they pitch the employer and say, look, if you add our procedures to your covered services list, it won't cost you a dime, and we will guarantee you that you'll save money on your orthopedic surgery costs. Well, any employer anywhere who's ensuring their employees' health is very interested in saving money on orthopedic surgery costs, which are very, very high. And so they sign up with us, and now we have CEOs of these organizations showing up at our annual assemblies, really crowing about how much money they're saving. But these are a fragment of the national population. The commercial carriers are not currently covering regenerative procedures. There is some spotty coverage. They'll cover a quote PRP injection, but quite frankly, they have no idea what it is we're doing. Now, we've had interest, Regenerative has had interest from Blue Cross Blue Shield, for example. They've looked at our data, but one of their main concerns is, do we have enough providers to take care of their patient volume? And the answer to that is no. There's just not enough Regenerative clinics to handle such an increased volume. But my standard response to this is that insurance covers are eventually going to cover this. And the reason I say that is because this is not magic beans. What we're doing is valid medical procedure. It is helpful. It is minimally invasive. There's minimal recovery time. After we do this, we get athletes back on the field much quicker. And it's a fraction of the cost of surgery. It is a tried and true in medicine that you go from least invasive to more invasive in your treatment. This is much less invasive than surgery. So it's naturally going to become part of the musculoskeletal orthopedic treatment algorithm for spines and joint care in general. But currently, no, it's not routinely covered by commercial insurers. The way we work in my clinic is that we see you under your insurance. In fact, we treat under your insurance. We may, if you've never had a steroid epidural injection, for example, we'll do a steroid epidural injection because sometimes those can be quite helpful and they can last for many months. So if you haven't had one, we'll do one of those. When it stops working, however, that's when I'll start talking to you about a platelet lysate epidural. And it's usually at that point that you leave the traditional algorithm. That's when there will be money out of your pocket for this procedure. At that point, we send you a treatment proposal with a full breakdown of costs for your review. If you have any questions about that, we talk. There's no arm twisting here. We're medical doctors. We're not insurance salesmen. And it's always your choice. There's no, we offer this because we think it's the best treatment going. Rebecca asks, how many of these procedures do I do each year? Thousands of procedures. Epidurals and ligament work and facet injections, we do these routinely. I do much less of injecting the disc simply because after we treat the nerves, we treat the ligaments, and we treat the arthritic joints, we often don't have to treat the discs. But this is something that is done routinely in my clinic. Let's see, how long have you been treating with Ortho Biologics? I have been treating with Ortho Biologics for about 8 years. I have been a Regenerative affiliate for 3 years. I've always known about Regenerative. I always wanted to be part of the network, but the contract they make you sign is something you think twice about doing, and I thought for about 3 or 4 years before I signed one. So I've only been a Regenerative provider for 3 years, but I've been treating with Ortho Biologics for about 8. Any other questions? Let's see, it looks like we might have a couple more. Oh, I don't see any new ones. Okay, if no one has any further questions, I will again thank you for your time. I really appreciate you making time on a Tuesday night in the middle of winter at the start of a new year to listen to my presentation. Looks like we have one more question here. Can orthobiologic therapy help in lumbar scoliosis? Yes, it can. This is a lot of prolotherapy. These are repeated prolotherapy injections to the ligaments and the thoracodorsal fascia of the human body. We find that if we do this repeatedly, we can, we certainly don't reverse curves. That's not what happens, but we can provide some more support, and this can reduce the pain of late scoliosis. Can it help iatrogenic cauda equina lesions? Platelet lysate is something we use around nerves all the time to very good effect. Cauda equina, by definition, is a damage to spinal nerves. So yes, this is not something I treat every day. I don't see iatrogenic cauda equina. I have treated cauda equina, but this is not a common diagnosis. But platelet lysate would be a very smart and helpful thing to do for something like that, yes. All right, everybody. Once again, thank you so much. I appreciate your time. Take care, get home safe.